Hello, welcome back. For this chapter, we'll be discussing the drugs used for dysrhythmia. Dysrhythmia is also known as arrhythmia. It basically means the rhythm of your heartbeat is not in synchrony, is out of beat, they call it. Before we understand the drug approach for dysrhythmia, let me give you the context about the physiology and the brief anatomy of the heart so that you could understand how these drugs were created to target each stages or phase of the cardiac muscle action potential. First, let us discuss the difference between atrial and ventricle. In the atrial, which is the top chamber of the heart, this is a simplified version of the heart. The top chambers of the heart is made up of two chambers, right and left, and we call them atrial for plural. And the bottom chamber also is made up of right and left chambers, then they are called ventricles. In the atrial, we have automatic functions. What I mean is they mostly contains nodes, nodal nodes, or specifically nodal cells. Nodal cells are automatic functions that include your sinus atrial nodes, your AV nodes, atrioventricular nodes, atrioventricular bundle, or simply called the bundle of His, and this would branch into left and right, and then we end up with the Purkinje fibers. All these structures are collectively called the nodal cells. By that I mean they have an action potential that is generated automatically. And that's a lot of drugs they are created to target it and modify the functions of these nodal cells. Another reason about the importance of these nodal cells is that since they are mostly found in the atrial, and if there is any pathology going on in the atrial, the top chambers of the heart, they are less severe in comparison to the ventricles. As a general rule of thumb, pathology or disease process happening in atrial is less severe compared to the ventricles because they have many automatic nodal cells. The ventricles comprise mostly of cardiac muscle. And in any muscle or structure as seen in the skeletal, you have molecular components such as actin, myosin, troponin, tropomyosins, and all on the side note, all calcium, which is used for contractions, all calciums in the of any cellular structures are usually stored in either what we call endoplasm endoplasmic reticulum, which is outside the heart muscle, or if it's inside the heart muscle, we call it sarcoplasmic reticulum. These both are the same, it's just because they are in different location. The heart, we refer them to as sarcoplasmic reticulum, and while the rest of the body is called endoplasmic reticulum. This is the storage site of calcium. Next, let's talk about the heart conduction system. This is a simplified diagram of how the action potential travels once it is generated from the nodal cells. Specifically, I'm referring to the pacemaker, or you can call it the SA node for short, or sinoatrial node. This is the beginning of the heartbeat. As action potential are generated, it is passed along to AV node or atrioventricular node. At the intersections of all the four chambers, we have what we call the bundle of His. And from here, we will split into two branch, left and right branch, which will travel in between the interventricular septum and wraps around the rest of the heart muscles, specifically the ventricles regions. And these tiny little fibers are known also as Purkinje fibers. So that is the overview of the heart conduction system. And anything could go wrong along this pathway. We measure the electrical activity of the heart by a test or device called EKG for short. A readout of the EKG would look like this. This is a example of a normal EKG reading. First, we have this little bump called the P wave, which is where your atria depolarize or contract. And this is normally activated by calcium. As you know, calcium is not only for pain transmissions, but also for contractions, squeezing. As the wave travels through the heart, in between the in between the interventricular septums and out and wraps around the ventricles via the Purkinje fibers, we have what we call the QRS complex. That is the combinations or the result of those traveling of those passage. This we call ventricular depolarizations. Depolarizations simply can be thought of as turning on. And so first P wave is atrium depolarized, followed by QRS complex, which is ventricular depolarizations. This ventricular depolarization is mostly carried out by the sodium ions. And lastly, we have the recharging effect, or what you should call it as repolarization, where the current is recharged for the next cycle. Again, this happens in the ventricle as a T wave. So this is in summary a typical EKG readings of the heart conduction system. Ventricular repolarizations is mostly performed by the ions potassium. There are differences of action potential generated as each ion moves into the cells. I wanted to bring this out so that you have clarity about the different graph that you would witness. Have a look at this action potential from different cells. Action potential is much needed to generate or pass messages from one cell to another. The first, on starting from the left of the pictures, that is the action potential of motor neurons. It is quite simplistic. It has only one spike. Likewise, the same for skeletal muscles. They both have similar action potential graph, although the transmissions and the membrane potentials are slightly different. However, the cardiac muscle action potential is much different. They are much wider, and as you can see in this diagram, it takes a longer time. They have 200 milliseconds. That's how long the action potential would last for each cardiac muscles specifically in the ventricular region, because that's where most of the heart muscles are located. As a general understanding, the atria is mostly consists of the nodal cells versus the ventricle, which is the contractile cells or muscles cells. And one more thing to note is that the nodal cells action potential are also different. This would be a good picture of the nodal cells action potentials. Notice that it has hyperpolarizations, where the membrane potential dips below the resting potential. If 70 is the resting potential, hyperpolarized means it goes beyond it. And this is important in order for the action potential of nodal cells to be activated. It must be hyperpolarized. It's funny, that's how it is. Because hyperpolarized is a state or condition where it is much difficult for you to get excited or depolarize again, because you have to raise yourself from below the basement past the resting membrane potential in order to reach threshold. So it's a difficult task to do it. So that's a funny situation with the nodal cells action potential. Okay, let's talk a little bit more details about the nodal versus cardiac muscle action potential. First, let's begin with the nodal cells action potentials. Have a look at these diagrams and just listen to this part to get an idea about the difference. You don't have to make any notes about it. In the beginning, what we call, I believe they call this at phase 0. Anyhow, in the very beginning, before action potential of the nodal cells are generated, we have what we call funny sodium channel. Funny sodium channels are denoted as IF, F for funny. It's funny, these sodium channels. It's because these funny sodium channels are only activated when it is hyperpolarized. Because normally when you hyperpolarize, you are not activated at all. For this reason, this action potential in the nodal cells are quite funny. They are activating the funny channels of sodium. And so when activated, the sodium channels open and rushes in. At the same time, it closes potassium channel. So if this is a cell, sodium would rushes in and make inside the cell more positive. It will also make sure to close the cells to prevent potassium from leaking out. So this will make it even more positive. At the same time as the membrane potential rises from 60 millivolt to 40 millivolt, the calcium channels are open very, very briefly. And so we call it T-type or transient calcium channel, the T-type channel. So the T-type channels would open. T-calcium would open slightly. And when this T-calcium open and allow calcium to rushes in, it would open the long-lasting calcium channel. And you will see the spike in this membrane potential until threshold. So now the cells is becoming more and more and more and more positive. This phenomena is called calcium-induced calcium release. And they are released from the storage inside your cell's organelle. Because they are located in the heart, we call it sarcoplasmic reticulum versus the rest of the storage of the calcium in other part of the body, which we refer as endoplasmic reticulum. Essentially, they are the same structure. Once it reaches thresholds, potassium channels would open. Potassium is positive, and so it will leak out. As potassium channels leak out, the inside of the cells become negative, or the membrane potential drops. As it drops, it closes the calcium channel, the long-lasting calcium channel, or the L-type channels. And this process continues until it becomes very, very much negative, even more negative than the resting membrane potential, and then it becomes hyperpolarized, super negative. And when that happens, the cycle starts all over again, and this hyperpolarization state activates the funny sodium channels. So you can see why this nodal cells is automatic. It's automatically cycling itself over and over and over again. Almost like a non-stop machine. Have a look at the action potentials of cardiac muscle in the ventricle. It basically looks like this. Okay, and it's divided into phases for simplicity and also when we're discussing drug targeting site. Like I mentioned all the time, drugs are very specific in targeting the desirable sites. So let's begin with phase 0. In phase 0, we have sodium rushing in to the cells. The cells always have containing potassium. As sodium rushes in through the pump, it makes the inside cell more and more positive. In the cardiac muscle, the sodium rushing in is through the fast channel. And that's just what it means. It's super fast rushing in. Sodium channels, once open, they rush through inside through this fast channel and quickly raise the membrane potential from -90 all the way to beyond 0, making it more positive. It is at this stage that the potassium channel is open and potassium start leaking out. And when potassium start leaking out, the membrane potential start dropping. From above 0 start dropping, and you can see this slope. But at the same time, it hit a plateau. How? Because sodium start rushing in via the long-lasting channel. So you have potassium going out, but you have calcium rushing in through the L-type channel. L means long-lasting channel. And so this kind of plateau or cancel out the difference between potassium leaving, making the cells slightly less positive or a little bit more negative, and the calcium coming in to make it more positive again. And so this plateau out. At some point, we have already finished phase 0, phase 1, and phase 2, where the calcium rushes in to balance out the potassium rushing out. At some point in here, you will see a drop in the membrane potential because calcium channel eventually close. So there's no more positive going inside the cell, but potassium continue to leave the cells. So it becomes more and more negative until it hit plateau, because at this plateau or stage, phase 4, that's the resting membrane potential or the resting membrane, and these are controlled by sodium potassium ATPase pump. It is at this stage where the potassium leaving and the sodium coming in are at equal stage. Potassium is still leaving because there's always what we call the leaky channels. Some are leaking, not a lot. But at this stage, potassium is still leaking, but sodium is coming in slowly. So there you have it. We have phase 0. Sodium quickly rushes in through the fast channel and spiked the membrane potential. At this stage, the cells open up for potassium to leave, and so the membrane potential drops, but this is balanced out by calcium long-lasting channel opening up to let calcium come in, so it plateaus out. But then potassium continues to leak out again, so the membrane potential continues dropping, and finally is stabilized by the sodium-potassium ATPase pumps until the next cycle begins again. This period actually is also called the refractory period, and it means at this period there is no action at all. Many drugs are created to target each of these phases separately. Let's get an overview of the class drugs. Drugs for arrhythmia are divided into different classes, ranging from 1, 2, 3, 4, and the miscellaneous type. So, in class 1, before we begin, I reminded you all the class drugs for anti-arrhythmia are actually what I call them as ion channel blocker, except for one, which is a beta blocker. Beta is from sympathetic, so it's blocking the sympathetic nervous system. So you can simply call it an anti-sympathetic agent. So let us begin our overview of the drug class. In class 1, we are blocking the sodium channel. And they are actually subdivided into class 1A, B, and C. 1A has moderate functions, 1B is the weakest, and 1C is the strongest. And you can see slightly from on the left side how this graph is. It affects this stage. This stage, if you remember, are called phase 0. That's where the sodium rushes in through the fast channel. You see how strong is the effects of 1C versus the rest of it, when it change, or should I say lower the membrane potential quite strongly. Class 2 is just your anti-sympathetic agent. Those are basically your laugh out loud drugs. They are beta blockers. It could be beta 1, beta 2, or the non-cardioselective one, which is both 1 and 2. And the effects it, and this diagram which shows it affects the autonomic nervous system, in particularly the sympathetics. Our heart is regulated actually by two branches of the autonomic nervous system, the sympathetics and the vagal form. Vagal simply refers to parasympathetic. And class 3 would be your potassium channel blockers. And it would affect mostly your phase 3 region. And lastly, but not the least, is your class 4. Class 4 is your infamous calcium channel blocker. And it would affect somewhat the region of phase 2. So in summary, class 1 is sodium channel blocker, and it affects phase 0. Class 2 will be your beta blockers. Those basically affect your autonomic nervous system, especially your sympathetic autonomic nervous system. Class 3 would be your potassium channel blockers, and that will affect your phase 3. And class 4 would be your famous calcium channel blocker, and that would affect your phase 2, including the phase of found in the nodal cells, including the calcium phase in the nodal cells. Because you remember that action potentials of the nodal cells is different from the contractile ventricle muscles cells, which is this one. Okay, now let's go into details about the drugs. Class 1, we discuss it as a sodium channel blocker, and they are subdivided into 3 versions: 1A, 1B, 1C. 1C is the strongest because 1C blocks the sodium channels on the His-Purkinje tissue. And I reminded you the anatomical location of this tissue. This is the His-Purkinje tissues. This is the bundle of His. This is the bundle of His, and this is the Purkinje tissues. So you can see that it covers almost the entire ventricles. For this reason, they are the strongest. And these are your drugs. Flecainide blocks sodium channel on His and Purkinje tissues. So it's very dangerous to use these drugs, and it can cause sudden death. Why? Because you see, it basically blocks almost all the conduction system of the heart. So in the EKG, you would see your QRS, the length or the interval of QT, and the PR intervals, they all would be very long, which means it takes forever to depolarize and forever to repolarize or recharge. So the class 1C flecainide for sodium blockers are dangerous to use, but sometimes they are used. The weakest one is class 1B. Again, they are sodium channels blocker. Good example of them are your mexiletine, and lidocaine. Yes, lidocaine is also a topical anesthesia, because the way lidocaine works and mexiletine is how they are sodium channel blocker. So they block sodium and eventually block calcium for contraction and pain. So they are quite useful as a local anesthesia. The mechanism of action is blocking sodium. Lidocaine and mexiletine are class 1B. They blocks those inactivated sodium channel. Sodium channel, they are dead. These are usually found in dead cardiac tissue following a myocardial infarction or heart attack. So class 1B sodium channel blocker, lidocaine and mixolydian are very, very good or useful for post-MI treatment, because post-myocardial infarction is the most critical stage. You have a higher chance of going right back into another heart attack, and it is even worse than the original one because of it produce tachycardia ventricular or fibrillation of the ventricle. Reaction potential just go up and down, spiking like crazy. And then the most common cause of death within an hour. And so class 1B is very useful and important. It will block this sodium channel that is dead already from being reactivated. Correction, it will block the inactivated or quote-unquote dead sodium channels of these myocardial infarcted cells. Class 1A has moderate actions in between, and they are blocking the fast-gated sodium channel. And phase 0, where sodium start going into the cells, are usually via the fast-gated sodium channel. So these are very useful when you want to slow down the heart. Actually, they are very useful to treat Wolff-Parkinson-White syndrome. This condition is a condition where you have an extra bit or extra current to generate another action potential. So instead of 1 bit periodically, you have 2 bit. Instead of you have two bits. So this is good for treating this type of syndrome. Class 1A. The drugs are the quinidine, procainamide, disopyramide. Let me help you remember the class 1A sodium channel blocker a little bit more. And to do that, let's study the hamburger anatomy. This is a picture of the hamburger anatomy. So it represents class 1A sodium channel blocker, and which is subdivided into A, B, and C. Okay? Well, A is actually your double quarter pounder. What I mean by that, this hamburger has two meat on it, 2 pieces of meat. So they call it double quarter pounder. Double quarter pounder. And in between, we have our lactose mayo. Mayonnaise, lactose and mayonnaise. And on top of these condiments, we have our fries and pickles. So double quarter pounder, lactose mayo, and fries pickles. Well, these are all class 1A ingredients. Double quarter pounder is 1A. That would be your disopyramide drugs, your quinidine drugs, your procainamide drugs. Double quarter pounder, disopyramide, quinidine, procainamide. 1B, that would be your lactose mayo. That would be your lidocaine, mixolydian. Okay, those are very fast action. You want it to be very fast. It blocks the fast channel. Okay, and 1C, that's the most strongest one of all. That will be your fries and pickles. That would be your flexcanamide and your propafenone. So there you have it. Hopefully this helps you remember some of the drugs for the class 1 sodium channel blockers. 1C, flexcanamide propafenone. Those are the potent or the most strongest one. Dangerous to use because they block the His-Purkinje tissues. Class 1B, which is your lidocaine, mexiletine, very, very useful for post myocardial infarctions because that's the dangerous zone within an hour after that. It blocks the inactivated sodium channel because this is a sodium ion channel blocker. And class 1A, that's your in-between or intermediate potency, double quarter pounder, disopyramide, quinidine procamide, which blocks the fast-gated sodium channel. Okay, now class 2 affects only your autonomic nervous system. Those are your beta blockers. And the beta blockers, they are useful for anti-arrhythmia, are usually your A to M beta blockers. The one that begin with the letter A and ended with the letter M. Those are your cardioselective beta blocker because the alternative is your non-cardio-specific. And those begin with the letter N onward, N to Z. Of course, there are exceptions. The exception is your Carvedillo and your Labetalol, the C and the L. Those actually has beta 1 and beta 2 effect plus an alpha 1 effect. So Labetalol, for example, are quite useful to be used for hypertension in pregnancy, L as in labor, and Carvedilol together with B, M plus Carvedilol, which is C, BMC, they are the most cardioprotective. B and C are the most cardioprotective. And you could see the reason why. Bisoprolol, metoprolol, and Carvedilol. You could see the other reason why they are mostly prescribed. Metoprolol, Carvedilol, they are the most cardioprotective because they are non-specific, non-cardioselective. Beta 1, beta 2, alpha 1. So class 2 is your beta blocker. Class 3 is very special. We'll come back and talk about it last. We talk about class 3 last. Class 4 would be your calcium channel blockers. Calcium channel blockers are used in many, many situations, ranging from the heart issues to the blood vessel issues relating to the heart. Okay, and those are your commonly prescribed verapamil, diltiazem, the dipines. The dipines actually are not used for anti-arrhythmia that often. The dipines drugs, you're like amlodipines, they are used mostly for blood vessel relating to heart conditions. So over this anti-arrhythmia, we tend to use the verapamil, the diltiazem. And they are used to treat atrial tachycardia or fast heartbeat due to condition from the atrial. Calcium channel blocker are your class 4, which is the last class. Now, going back to class 3, which is your potassium channel blocker. That means it mostly blocks potassium. And those are your drugs called amiodarone and sotalol. Sotalol is your non-cardio selective beta blocker because it's the letter S right there. Amiodarone is also a very commonly prescribed anti-arrhythmia drug. Amiodarone. Amiodarone is very special drugs. These drugs, although is classified as 3, but actually these drugs works as sodium channel blocker. It's also a beta blocker. It's also a potassium channel blocker. And lastly, a calcium channel blocker. So it can treat any types of arrhythmia arising from atrium or ventricle. But we classify them as class 3 potassium channel blocker, the amiodarone. But actually, they blocks all the class functions, same like the rest of the class. Very, very special, these drugs. Because this drug is commonly used, we always have to be aware of the adverse effect. If you take a look at amiodarone, it has this word IO in between. That's iodine, because its molecular structure consists of iodine, and for this reason, it can cause or affect hyper and hypothyroidism. So watch out for that. The rest of the miscellaneous anti-arrhythmia drugs, those are your adenosines. Adenosine with the letter A, so it will block the AV nodes. So AV nodes pathologies are usually resulting in supraventricular tachycardia, SVT, supraventricular tachycardia, SVT. And adenosine blocks AV nodes. And magnesium is another one found in supplement or drugs. Magnesium actually is written as Mg2+, and this 2+ is important. That's how it can block the sodium, which is Na+, by displacing sodium. It displaces sodium, so it displaces sodium from entering into the cells to further depolarize or activate the action potential. So magnesium blocks sodium entrance, and so the cells don't depolarize by the difference in the charges. Mg2+ 2 versus sodium 1+. Okay, so this concluded the lectures for these chapters, and I'll see you on the next one.